one of the most exciting presentations that we had this year at ASCO 2020 was the results of KEYNOTE-355 and the potential of adding a different type of immunotherapy in our patients with triple-negative breast cancer. Laura, can you walk us through that trial?
Sure. So prior to this, pretty recently, we saw the approval of the combination of atezolizumab and nab-paclitaxel for the first-line treatment of PD-L1 positive metastatic triple-negative breast cancer, and that was based on the IMpassion130 trial. So then with KEYNOTE-355, this trial looked at the addition of pembrolizumab versus placebo to chemotherapy, and that chemotherapy could either be a taxane or gemcitabine carboplatin. So unlike IMpassion130, we saw some different chemotherapy backbones here. And at a median follow-up of 17.5 months for the pembrolizumab plus chemotherapy arm and 15.5 months for the chemotherapy plus placebo arm, the arm with pembro had significantly improved progression-free survival, specifically in patients with tumors with a combined positive score of greater than or equal to 10. So overall, the trial showed us that with several different chemo backbones, you still saw a statistically significant improvement with immunotherapy in PD-L1 positive patients.
What did you think about the subset analysis that looked at the gem-carbo versus the taxane? It did kind of look like the pembro with the taxane looked better than the gem-carbo. I know we're not supposed to look at subset analyses, but they do show them. So any thoughts on if the chemo backbone matters?
I think it's an important question. You know, I know from the neoadjuvant setting, it does seem like combining combining immunotherapy with actually an anthracycline does seem more helpful. So it does beg the question, you know, about the chemo backbone. And it makes sense that it would be important. So I think that's something to pay attention to, but also I think it's been challenging in that sometimes nab-paclitaxel isn't the option we want to use for some patients, especially if they might have prior neuropathy from earlier treatments. So, you know, I think overall, at least, you know, this may help us feel comfortable with other partners, but I think a lot more work needs to be done to figure out the ideal chemo partner up front.
In IMpassion130, when we use the SP142 PD-L1 assay, it looks like about 40% of patients are positive for PD-L1 greater than 1% on the TILs. In this trial, do we know what proportion of patients had a CPS score greater than 10? I think it was somewhere around 40 or 50% too. But you know, we'll have to see what the approval is if we get this approval. But you know, how would we decide between pembrolizumab and atezolizumab? Any thoughts?
There's some conflicting data out there. I mean,
I wasn't going to bring it up, but there's a press release, and you know, press releases for the investigator or the investors. They're not for the medical oncologists. But in IMpassion131 with paclitaxel and atezolizumab and PD-L1 positive triple negative breast cancer was negative. We haven't seen the data, but we know it's a negative trial. So now, I mean, it hasn't changed my practice yet. I have not seen the data. We don't have pembrolizumab approval, but how in the world are we going to reconcile those differences?
I don't know, but it was strong enough to change one of the clinical trials I'm trying to open called Opportunity 170, which would be PD-L1 positive arm versus PD-L1 negative arm with a drug I'll talk about in a second, the ipatasertib. So they're taking it seriously enough to change some of the clinical trials.
Yeah, I know there's a lot of speculation out there. You know, the IMpassion130 was based on a subset analysis, pre-planned perspective. So it is a subset analysis previously, and does the steroid component that you have to give with paclitaxel matter? Is the albumin-bound portion of paclitaxel important? There's so many questions that we're going to have to answer in the next couple of years to figure out what the best treatment for our patients is.
Yeah, the reason to use the Abraxane was to avoid the steroid pre-meds. So
exactly,
it is very interesting.
It's interesting. More to come. Nothing's easy. Everything's always gray. So moving on to other targeted therapies that are really exciting in the field of triple negative breast cancer would be the field of PARP inhibitors. So we have an approval of both olaparib and talazoparib in our patients that have germline BRCA mutations. But one of the main questions in the last couple of years has been, is there another subset of patients with triple negative breast cancer that may benefit from either PARP inhibitor therapy or the addition of PARP inhibitors to chemotherapy? I think one of the most interesting trials in terms of precision medicine and PARP inhibitors that I've seen in the last few years was TBC-RC48 that was presented this year. Julie, could you tell us a little bit about that trial?
Yeah, of course. So TBC-RC048 looked at olaparib in 54 patients with metastatic breast cancer who had either germline or somatic mutations in DNA damage response pathways. So the patients were split up into two cohorts. Cohort 1 included patients with germline non-BRCA DDR mutations. So those were mostly things such as PALB2, ATM, and CHEK2 mutations. And then the other cohort was for patients with either somatic BRCA mutations or DNA damage repair mutations. And what we saw in this trial was that responses were gene specific. So responses were only seen actually in patients who had germline PALB2 or somatic BRCA mutations. And then responses actually occurred across all subtypes. So we saw responses in TNBC, in hormone receptor positive, and in HER2 positive patients. So it really did seem like the genes were the important players here and not the breast cancer subtype.
I was really excited to see that data. I think there were 11 patients treated with germline PALB2 mutations, and 9 of them responded for an overall response rate of something like 80%. And some of those responses were durable. I mean, you know, beyond 6 months. So I'm really excited about that. And then we've had ovarian cancer data that has shown that PARP inhibitors do work in somatic BRCA mutations. So, you know, this would also support that. And I think they are going to expand those cohorts, and with the hopes of, fingers crossed, an approval, because I would love to be able to offer that to my patients.
And I like this data a lot. The PALB2 is a binding partner of BRCA, so that kind of makes sense. ATM is more of a DNA damage sensor. So I like having this data now because I have a few patients who have ATM mutations and many more who have CHEK2 mutations. And I've always wondered, should I be giving them a platinum instead of one of these other regimens? So this I think is very helpful.
I agree. It's, you know, when you can see the mutations and the waterfall plots are so small, you know exactly which patient is yours. And unfortunately, one of my patients was a CHEK2 patient, a CHEK2 patient that just did not respond at all. And she came off pretty immediately. So not as optimistic about PARP inhibitors in CHEK2 or ATM or, you know, some of the other HRD mutations. But I think this is promising data. And it also supports Melinda Telly's talazoparib data, which we saw before at ASCO last year. So moving on to the next study that looked at PARP inhibitors was phase 2 randomized trial of cisplatin with or without veliparib in metastatic triple negative breast cancer and or germline BRCA associated breast cancer that was presented by Dr. Sharma at ASCO 2020. Julie, can you tell us a little bit about that trial?
Yeah, so the thought behind this trial is that about half of BRCA wild type triple negative breast cancers have homologous recombination deficiency, resulting in this BRCA-like phenotype. So in this trial, patients were actually divided into 3 groups. There was a germline BRCA mutation group, a BRCA-like group, and a non-BRCA-like group. And what we saw was the addition of veliparib to cisplatin increased PFS in both the germline BRCA group and the BRCA-like groups. It was actually only significant in the BRCA-like group, with the caveat that the BRCA group only accrued to about, I believe, 60% of their expected accrual at the time that this was presented. And no benefit in terms of PFS was seen in the non-BRCA-like group. So again, looking more at the mutations rather than the type of breast cancer, guiding where we may in the future be using PARP inhibitors.
And in the BRCA-like group, the median progression-free survival was 5.7 versus 4.3 months, I think. So not a huge difference. And I do wonder what the addition of, it seems like the addition of a PARP inhibitor would be pretty toxic in terms of anemia and neutropenia. So I'm not sure where this will shake out in clinical practice, but certainly interesting in terms of, it seems like we should be thinking more thoughtfully about what a BRCA-like group looks like and what they might benefit from.
And also thinking more thoughtfully about what to combine with a PARP inhibitor, because the platinums have terrible myelosuppression toxicity, so do all the PARP inhibitors. So most trials with the combination of chemo and a PARP inhibitor have started at full dose chemotherapy and tried to titrate the PARP inhibitor up, but not achieved what would be a monotherapy dose in the ovarian cancer setting, for example. So something like, something that's not so myelosuppressive, like an anthracycline, I said it, Doxil, something like that.
I can tell you about my baby is, my first investigator-sponsored trial is looking at triple-negative breast cancer patients who are platinum responsive. So they've gotten first or second line platinum with metastatic triple negative disease, and they either have a partial complete response or stable disease. And then those patients get randomized to either single agent olaparib or single agent olaparib plus durvalumab to sort of look at, can you do a maintenance PARP inhibitor and get some of these patients off chemo that might have this BRCA-like phenotype. And we're about 2/3 way accrued, and we'll do some pretty robust correlatives, but also looking at maintenance strategies or sequencing of PARP and chemo, I think is potentially interesting since the combination is tough.
The PARP inhibitors are not easy drugs to take either. I kind of dabble in the gyn-onc, and they have a lot of GI side effects.
Yeah. And then the last study to discuss in terms of PARP inhibitors in breast cancer in the last year was presented at ESMO Breast 2020. And that was looking at the results of the phase 3 Brocade-3 trial, which was veliparib added to carboplatin paclitaxel in patients with HER2 negative BRCA, germline BRCA associated breast cancer. Julie, since you're our resident PARP inhibitor expert, can you lead us through that trial as well?
Sure. So despite Kelly's wishes that we would combine a PARP inhibitor with a non-platinum, we have another veliparib plus platinum trial here, plus taxane. So again, not a huge benefit in terms of PFS, but we did see a 16.6 month PFS versus 14 months in this trial. So putting the SWOG and the Brocade-3 data together, we are seeing an improvement in PFS, though it's not striking in the germline populations.
Yeah, it would be interesting to know what the sequence of single agent PARP and platinum is, and then versus the combination. And I think you'd have to see a pretty significant benefit with the combination given the toxicity to just not do them sequentially, in my opinion.
There ought to be a cross sensitivity to there is a cross sensitivity of platinum and PARP. So I'm not sure of the utility of using them together so much, as we already know that if somebody is resistant to a platinum, they're probably not going to respond to PARP. So why use the two together? Cancer is probably going to be resistant to both if it's resistant to either.
We just were talking about that today in our molecular tumor board. We had a patient that progressed on PARP, and she has brain metastasis. So the question was, do we put her on sacituzumab or a platinum? And we hadn't resequenced her, but we decided that it might be interesting to resequence her and see if she had a reversion BRCA mutation, because then if she had a reversion BRCA mutation, maybe then you wouldn't want to challenge her with the platinum. But this is also a lot of speculation, and I think we just don't know what the value of platinum and Parp are after progression on one or the other, and that's why a lot of Parp trials, you have to either be platinum responsive or platinum sensitive, or not have progressed on platinum in the last 6 months or something like that. But more questions to answer down the line.
In addition, with this trial, very seldom do I use doublet chemotherapy in the metastatic setting. And so now we're looking at doublet chemotherapy plus a Parp inhibitor. I don't know how applicable that is to my everyday practice, but I think going back to the question that Sarah first posed when we started talking about Parp inhibitors is, who is the right advanced TNBC patient to treat with a Parp inhibitor? And as of, where are we, August 20th, 2020, I don't think we have the exact answer for that yet outside of germline BRCA mutations. But I think these trials are giving us a glimmer into gene-specific reasons that we may end up using Parp inhibitors down the road.
Definitely. So we're going to move on to our last subset of triple negative breast cancer patients. I think I can see in my head in the next, we're really starting to characterize triple negative breast cancer between patients that might benefit from immunotherapy. And right now that seems to be the PD-L1 population. Right now, the only class that we know benefits from Parp is those patients with germline BRCA mutations. Now we have germline PALB2 mutations and potentially somatic BRCA mutations. Theoretically, there could be a subset of BRCA-like. We need the right biomarker. We don't have that yet, but that's definitely intriguing. And now the next subset to move into is patients that have alterations in the PTEN, PI3 kinase, AKT pathway, which has been the subject of the LOTUS trial. Kelly, can you tell us about LOTUS?
Sure. So LOTUS was a phase 2 randomized placebo-controlled trial in the first-line metastatic triple-negative breast cancer setting. Patients were given paclitaxel combined with either the AKT inhibitor, ipatasertib, or placebo. They assessed markers of an overactive PI3 kinase pathway, which would be activating mutation in PIK3CA, activating mutation in AKT, or low expression of PTEN, which inhibits the PI3 kinase pathway. In the median progression-free survival overall was better in the ipatasertib arm versus the placebo arm with a hazard ratio of 0.5. If the PI3 kinase pathway was overactive, then there were better effects. They just presented the survival analysis at ESMO Breast 2020 with a median overall survival in the ipatasertib arm of 25.8 months versus 16.9 months in the placebo arm. So now there's an ongoing phase 3 clinical trial called Opportunity 130 that follows this. So I think this data with the overall survival is particularly promising, even though the median progression-free survival wasn't as exciting as everybody had hoped. The AKT inhibitors, I think, tend to be a little bit easier to tolerate than the PI3 kinase inhibitors. Do you guys have a lot of experience with the ipatasertib? No?
I don't have experience with the compound yet, no.
We've had this trial and others, and I would agree that it does seem like the tolerability is better compared to alpelisib, for example.
Mm-hmm.
I'm excited for a potential option for our PD-L1 negative patients. I feel like they've been left in the dust in the last couple of years, so I'm hopeful about this pathway for them. About what percentage of triple negative patients have these alterations? Would you say between 20 and 30%?
It's much less than in the hormone receptor positive patient cohorts.
Yeah.
But since we're not really assessing with these activating mutations, we're probably missing a lot of patients actually who actually do have an overactive PI3 kinase pathway. We just don't have the ability to assess it anymore. since the PI3 kinase pathway is one of the escape pathways for a lot of our breast cancers.
Absolutely, and it seems like we have some data that PTEN altered tumors may be resistant to immunotherapy. So it's nice now that we, are exploring another option for these patients.
Absolutely.
All right, well, a big thanks to my guests today. This was really fun. Dr. Kelly McCann, Laura Spring, Julie Collins, thank you so much to our viewing audience. I hope that you learned something. I certainly learned a lot. And we hope that you enjoyed this OnC Live presentation of Breast Cancer Talk. We'll see you next time.